Okay. Right. Thanks very much indeed. Arlene, over to you.
Thank you. Can I just remind everybody that the meeting is being recorded and will be placed on websites for public viewing. And I'll now take a roll call for the minute. As noted, Councillor Lynn is absent. Bob Benson.
Present.
Councillor Toland.
Yeah, I am here.
Councillor McHugh.
Present.
David Cheek. Present. Pauline Carrollton. Present. Lynn Lloyd.
Present.
Dave Berry.
Present.
Christine Jones. Present. David Wilson.
Present.
Jane Smith. Present. With apologies from Sanjay Pillai. Raymond Marshall.
Present.
Jim McFarlane.
Morning.
Christina Cooper.
Present, darling.
Nicola Stevens. Present. Martin Sloan. Present. David Shaw.
Present.
And that concludes the roll call. Will I just carry on, Chair?
Yes, please.
So item 1, apologies are already noted. Item 2, declaration of interest. Are there any declarations? Not seeing any declarations, so that takes us on to
Arlene,
item.
Arlene, if I may, are there any members of the press here today? Are there any members of the press here today?
Yes. Yes.
Okay, thank you.
So item 3 takes us on, sorry, that takes us on item 3A, which is the minute of the previous meeting, which was held on the 24th of June, and it's submitted for approval.
Okay, any comments on the accuracy of the minute?
Could I just add something?
Who's speaking?
It's Nicola, sorry.
Oh, hi, Nicola.
Thank you. It's just to note that on page 5 of papers, the out of hours appendix B documents were for circulation, but I don't think we've actually received those as yet.
I pick up that one, yeah. Yes, so the documents were embedded documents in the previous reports, and we couldn't open the embedded documents. I have gone to colleagues in Angus IJB who actually submitted the reports to see if we can get the original copies that have been embedded ones, and I'll get those passed on to Arlene to get them shared out. So apologies for missing that one.
Okay.
There was one more. There was one more item on as well on the minute, and it's just for public noting that the increased funding for that out of hours formed model, Angus did approve later the last IJB day that we had in Dundee for the additional funding, so there's no impact on Dundee IJB funding.
We don't need to change the minute though. This was after, was it?
Yes, yeah.
Could you get?
Sorry.
Thank you.
Okay. With that, with those comments, can we now move to approve the minute? Okay, then it's approved. That now takes us, Arlene, on to the next one.
Yeah, so that takes us then on to item 3B, which is the action tracker, which is submitted for noting.
I take it there are no comments in the silence, so we'll just note that.
No one. I have a comment. Bob.
Sorry, okay, is that you, Dorothy?
Yes, or a question rather. Item 6 on the action tracker.
Yeah.
Strategic Planning Advisory Group. Discussion would take place about the feasibility of having an older person representative and wider representation on the ISPAG. I wondered if that discussion has taken place.
So I can answer that, Dorothy. So we've had a number of discussions over recent meetings about the lived experience representation at both Strategic Planning Advisory Group and other groups, and the agreement is that we'll move to encourage that from existing groups and representation. So it's certainly feasible, but the detail of that, I think we need to discuss out with the meeting with the relevant groups in terms of where representation might best be supported from. So happy to take that forward outside the meeting with relevant colleagues.
Okay, thank you.
Any further comments on the
Well,
action track?
Bob, it's David here. Just on there's a lot in there on the financial monitoring position of various dates.
Can you give me the number reference, David?
Oh, it's number 1, number 4, they're all the same. 8, all different dates for the financial monitoring. But my point was it's showing us complete because we've allocated, I think it probably is in the development session in November, but I'm just thinking it's probably not complete until that date's agreed and gone through. So it's not.
Okay, I take that for David. Okay.
Yeah, so
We think that is an ongoing.
yeah, that's Bob.
Okay. Any further comments?
I have a question on item 7 on the tracker. This concerns the reinstatement of the Frailty Strategic Planning Group. And the comment says that an initial meeting is set to develop terms of reference and membership. I'm interested in having some detail on timing for this.
I can answer that. So we're just waiting on Kerry coming back from annual leave, and then we'll be getting out on the initial group that we've discussed already, to try and get that initial meeting. I think hopefully within the next 4 weeks.
So does that mean that the action is in fact not complete?
Yes, that's probably ongoing. Yes.
Yeah. If we could amend that, please. Thank you. Okay. Any final comments?
Nothing else in the room, Bob.
Right. Thank you very much indeed, Dave. Now that takes us on to the next part of our work, which is to do with the deputations. And I believe that we are having a deputation from Unite, and allied to that, we will also discuss that in the context of item 6, which is the annual performance report 25-26. Okay, so who's going to speak on behalf of Unite today then?
So I'll let frontline colleagues introduce ourselves. Bob, just to say I've advised the deputation that we have 7 minutes to address the IJB, and after that there'll be time for questions from IJB members in relation to that. So,
okay.
Okay, thank you. My name is Elaine Stewart. I am a social worker based in one of the community teams at Kingsway Care Centre, and I'm a workplace rep for Unite.
I'm Graham General Conveyor at Construction Services.
So thank you for your time. So our deputation is in relation to item agenda of the annual report, which highlights that Kingsway Care Centre has been providing a valuable service to the people of Dundee, with the Mental Welfare Commission report assessing that the quality of care at Kingsway Care is good, and that was 25-26. It was stated that multidisciplinary teams work together to support recovery in a supportive and engaging environment. This was certainly my personal experience in supporting a patient on one of the wards, and I was able to liaise with the nursing staff, the consultant psychiatrist and the family. We were all in the one place. The only action in relation to the Kingsway Care Centre building identified in the Mental Welfare Commission report is, to quote, to address some environmental issues, e.g. the garden, and progressing repairs in parts of the estate. The minutes of the IJB meeting on the 24th of June evidence that Councillor McHugh raised the issue of the possible closure of Kingsway Care after reading it in the press, and she wondered when the IJB was going to discuss this. She was advised that this was not a matter for the IJB, as beds in Kingsway Care are a commissioned service. She was advised that all was currently known was that the NHS was carrying out an options appraisal
of which the IJB would be informed of the outcome completed. Councillor McHugh advised she was going to explore this further. 4 weeks later, it was announced that Kingsway Care Centre would close. I'm looking to see where the partnership working was in this. It is noted that the closure of Kingsway Care is also not on today's agenda. Unite the Union believes that there has been no proper consultation, particularly with the public, no transparency, no accountability with regards to this decision, which will leave the people of Dundee with no inpatient provision for people over 65 with mental health conditions. At a staff engagement session, it was announced that the lease of Kingsway Care ends in January 27, but staff will require to vacate the building by November this year. That's 3 months' time. And clear information on how this will be achieved is almost non-existent. Unite the Union is requesting that the IJB, as the strategic arm of the partnership, provides clear and factual information on all of the information and assessments that were taken into consideration to support this decision, to give confidence that due diligence was carried out, and to provide evidence of how these new arrangements provide services that the people of Dundee want. There are key policy documents that underpin the provision of health and social care services across Scotland, and the Union would like to understand how they were taken into consideration in this situation. Looking at the national health and wellbeing outcomes, the priority for Scottish ministers is to improve people's experience of health and care services. Services should be person-centred. The NHS and local authorities have shared priorities. Responsibility and accountability for service delivery is carried out jointly. The 9 national outcomes have a foundation in supporting people to access quality services in their local communities. Resources should be used effectively and efficiently. We know that the plan for excellence in health and social care in Dundee is derived from these national outcomes and is aimed at improving the health and wellbeing, reducing inequalities and enhancing access to services across the city. Within the annual report, a review of the plan for excellence is referenced, and feedback from this review is clear that people value community-based services. But there's more to be done. People want services to be easier to access and better planned, and planned with the people who use the services. The annual report itself also references the importance of local community support that helps reduce barriers such as travel and costs. There has been public consultation for the Mental Health and Wellbeing Strategic Plan for 2026-2031, with an event being held at the Steeple Church. Don't know if there was the possible closure of Kingsway Care was discussed to gain feedback from the public at that time. The annual report highlights that the IJB is responsible for making sure that health and social care services are planned and funded in a lawful, fair and responsible way. This includes ensuring that public money is used carefully and has the greatest possible impact for the people of Dundee. Our deputation is that the closure of Kingsway Care will have the greatest impact for the people of Dundee, but not in a positive way. While it's acknowledged that many of the services referred to in the annual report do not focus on inpatient facilities, the IJB is the strategic arm of the partnership, which involves the NHS as well. People who are in receipt of health and social care services are often the most vulnerable in our society. We know people are living longer and can require inpatient mental health services when they are over 65, but this is no longer going to be available to the people of Dundee. The annual report contains information of all the good work and the determination of the partnership to provide robust and effective services to people in their communities. But this will end when someone requires to be admitted to hospital with a mental health condition. This completely contravenes the spirit and philosophy behind the national outcomes and the plan for excellence in Dundee.
So on the back of that, we've got a few questions. So when do we know whether we're moving out of Kingsway Care Centre? In relation to the feedback from the consultation with the public, where's the importance of community services was fundamental? Was the public ever consulted at the proposed closure of Kingsway Care Centre? People said they want to be consulted for the services to be planned together. What was the equality impact assessment carried out? Staff engagement sessions, these questions were never answered. If feedback is clear that community services are fundamentally important to the community, how will this be achieved with no inpatient beds for Dundee for over 65 with mental health conditions? How are the 85-year-olds expected to visit their loved ones in Forfar and Perth? How does this reduce barriers? we also believe the beds are dropping from 36 to 23. Were the repairs in the part of the estates outlined in the MWC inspection ever carried out? Has a full structural engineer report been prepared and published in relation to the requirements and cost of repairing the roofs? What's the NHS's rationale for not repairing the roof when it was first realised that this was needed? The renovation was required to prepare multiple sites for relocation of both inpatients and community teams seems excessive. Staff have been asking for sight of the cost-benefit analysis that has been completed in relation to this, but this has not been forthcoming. How do members of the IJB feel the closure of the Kingsway Care Centre supports the aim of health and social care services are planned and funded in a lawful, fair and responsible way? This includes ensuring the public money is used carefully and has the greatest possible impact for the people of Dundee. In summary, Dundee will no longer be providing inpatient facilities for people with over 65 with mental health conditions. Despite asking for sight of a quality impact assessment and a cost-benefit analysis, this has never been produced. The good work of the partnership outlined in this annual report is at risk of being forgotten by removing this vital service for the people of Dundee and their families. On a personal note, my granddad used the service and one of my very good friends' dad used the service. Unfortunately, they both passed away, and I know how important it was for both of our families. And for not to have that in a community of Dundee, I think personally is shocking. I think we should be fighting for this to be kept in Dundee and not asking people, pensioners, to get on buses to go to Perth, Murray Royal and Forfar to meet loved ones, especially in all seasons. Lastly, Unite is calling for an extension to the lease for allowing further time for meaningful planning, a cost-benefit analysis to understand the financial rationale behind the decision, an assessment to understand the cost of making the building safe and fit for purpose in the long term, and finally, if the building cannot be suitably repaired, an assurance that a centre will be built or identified to ensure there's no loss of inpatient psychiatry for older services in Dundee, where all the teams could work together to give the tenants of Dundee better service. Thank you.
Thanks very much indeed. Dave, do you want to make an initial response to that? And also, could you add the within that the roles and responsibilities of the Integration Joint Board in relation to this? Thank you.
Yeah, thanks, Bob, and thanks for the deputation. There was a lot in there that you described that I've said differently what we heard those comments coming back. So I think I just need to be kind of clear in terms of the role of IJB within this particular setting. So there's the distinction between the IJB itself, which has its which plays a strategic commission and a oversight. The set of health and social care services that the partnership delivers. So is that distinction between Dundee Health and Social Care Partnership and the IJB itself. In terms of the integration scheme, which governs how the IJB works and how the interfaces with the other ones in terms of the NHS side and Dundee City Council, it's the responsibility of the local authority and the NHS side to for the operational management of those services. And that includes the management of all the day-to-day functions related to those services, but also includes the configuration of those services. So in terms of the IJB's role, the IJB is the commissioner of those services. Now the way we commission those services is kind of quite high level. So we kind of say we want NHS side to provide psychiatric related services to all citizens of Dundee. What we can do as an IJB is to direct the health board or the council for that matter and where and how that service is delivered. So there's a big distinction between a decision that was made by NHS side in relation to the estate, which again is not something that the IJB has delegated to it. So property matters are not delegated to the IJB to make decisions on. And it's therefore an NHS side decision that was made to not renew the lease continue with the lease arrangements that have been put in place. So I think that the difficulty for the IJB in this regard is around its role around any sort of decision making and influence around how those services are provided. Because it's not something that's within the integration scheme to do. So as I say, just to repeat, we as an IJB do not have a say on the configuration of the services. We commission it from the partner bodies to deliver. So again, well, absolutely respecting the views and comments that have been made in the recommendation today. There isn't a decision that the IJB has taken. It's not an IJB responsibility in terms of that delivery. And it's, from my perspective, I have two hats sitting in this role. I'm the chief officer of the IJB, so my role here is around strategic commissioning and planning of services. I'm also the executive director of the Social Partnership, and I'm therefore, from an NHS perspective, the lead officer in the development and implementation of the contingency plan. Unfortunately, in terms of my capacity today, I don't think I'm in a position to answer all the questions that are put to this IJB perspective. And would suggest then that's something we need to kind of take back through NHS side. So
Okay, thank you very much.
I'm sorry, open up to questions anyway.
Thank you, David. Happy to take questions.
Dorothy's got another.
I have a question. Dave said in his response that this was not a decision for the IJB, and I think we all understand, the people that sit around this table understand the difference between strategic and operational. We accept that, but Section 5 of the Dundee Health and Social Care Integration Scheme says the parties will advise the Integration Joint Board where they intend to change operational service provision in any area of provision, including support services, that will have a resultant impact on the strategic plan. And my view, very strongly held view, is that this decision, this operational decision by NHS side to make significant change to these services for older people's psychiatric care in Dundee will have a negative impact on our strategic plan, and on that basis should be discussed at the Integration Joint Board. That's not a question, that's a statement.
Yeah, I got that, Dorothy. Thank you. And Dave, do you want to respond to that?
If I could, sorry, Bob, could I just add a question then?
Oh, sorry. Thank you, Dorothy.
What advice then, according to the regulations within the Dundee Health and Social Care Integration Scheme then, what advice was given to the Integration Joint Board about this intention to change operational service provision such that this would impact our strategic plan? What advice was given to us?
So, Bob, I don't know if you want me to come back.
I assumed the question was directed at you, Dave, so please continue.
So I suppose in terms of the governance side of things, I understand the questions for the session would be around questions to the deputation itself, and given that we don't have a specific item on the agenda for this issue today. So I'll take advice from Roger if you think that's appropriate to respond to that.
Roger?
Thanks, Bob. I think it would be appropriate for you to consider the position of the patient to that respond to Councillor McHugh separately.
Okay, I have a question for the deputation. You spoke about, I can't remember, sorry, which one of you spoke about multidisciplinary teams working together? Now, the proposal from NHS side is to split this service into 3 geographical areas, so community mental health support will remain in Dundee. Assessment and treatment for older people will be in Porter or Perth. So what will be the effect of separating these three parts of the service
I think when
on older people?
Well, I think that the reports that I made reference to are very clear that people value these community-based services. So, you know, if someone becomes an inpatient currently at Kingsway Care, there's a wraparound service there. The worker that they've been working with in the community is still available. And the familiarity of where the place is, they may have been to the outpatient appointments in Kingsway Care. So if they then become an inpatient, they're already used to the surroundings. And that won't be the case anymore. The families are used to, because you might come for an assessment, a dementia assessment as an outpatient currently at Kingsway Care. So you know the environment, you know everyone that's there. That will be very different because everything will move, the community-based services will move to RVH. That also means it becomes more challenging for the mental health nurses who are in the community to have that close liaison with their consultant psychiatrists. So, and then obviously myself in terms of the social work teams, we all work really closely when we're having patients. But that, we won't be able to do that.
Could I just ask one more question?
Yes, please, that's fine.
Someone also asked, raised the issue of quality impact assessment. Now you're asking if an equality impact assessment has been done.
Yeah.
Have you had an answer to that question? Could someone answer that question?
Can I come in, Bob? I think it would be appropriate for Councillor McHugh to indicate who she feels should have carried out the equality impact assessment.
NHST side, I believe.
That's a question that would need to be directed to NHST side.
We do have representatives from the NHST side on the board.
That's correct. I think it's also important to bear in mind that, as with the council and as with many organisations, some decisions are taken by a board and some are taken by officers. I understand this was a decision taken by officers, so I don't think it would be fair or right to ask members of the NHS board to comment on the decision that was taken by officers.
My understanding is that the Equality Impact Assessment is regulated under the Equality Act of 2010. I don't imagine that would be left to the discretion of officers whether the organisation abided by the legislation or not. I would imagine that any decision on whether an Equality Impact Assessment is made would be taken at board level, not at officer level.
Obviously, I wouldn't be in a position to comment on that, but that certainly wouldn't be the position in the City Council, for example, where EQIAs are carried out by officers. So my suggestion, Councillor McHugh, would be that that would be taken up with the NHST site chief executive.
And so I think Jim.
And
Dave,
Dave,
I'm trying to work the room, so.
sorry, I gathered that. It's quite difficult for me to see here. Thank you, Roger. That's very helpful. Dave, do you want to take up more questions there for me?
Yeah, certainly. So, Jim, first, and then someone.
Yeah, thanks. I'm Jim Fallon, who news outlet on the IJB, and thanks to Elaine and Graham for even just coming along and making the points. I think it's really important as an IJB that, you know, we are open, you know, to question and scrutiny and stuff like that. And we should always kind of welcome that. I've got kind of a few points, and I've got a couple of questions as well for the deputation, because I do think it's important around, although I understand the explanation around, you know, operational responsibility, whether it comes under Dundee City Council, NHST side, absolutely get that. But then as an IGP, I think we should have the right to kind of hold that scrutiny, or at least take a view on stuff and question some of that. And that includes, in my opinion, you know, the point that Dorothy made and others made at the deputation about the quality impact assessment and whether that could have been shared with us, you know, even earlier. But we'll have a discussion over this. And I do think, as the Dundee IJB, you know, we should be opposed well, certainly from a trade union side point of view, Dundee City, we are opposed to all cuts in jobs and services or threats to them. And as a Dundee IJB, we should be arguing that if the service is currently provided to people in Dundee, then that should remain so in that sense, and to importantly meet the predicted future demand for some of those services and stuff like that. So I mean, my question is probably more Elaine, because she's probably more around this, is around, if your current service users or are expected to go to Perth or Forth for that, not just the impact on them, which you've kind of already outlined a bit, but also do you have a concern then about the impact on your own job role and your colleagues' job roles and your future of those jobs? Because obviously you're employed by Dundee City, you don't cover Angus or Perth and Kinross, so is that a concern for you? And I suppose the other point of it, I think it was great with the question around kind of the building itself, because I totally understand the building, and I do have a lot of concerns about the building itself. First of all, because it's privately owned in the first place, and I don't think public money should be going to the private sector to provide some. So again, in the longer term, I think somebody did say around, building either a specific provision in Dundee or adapt existing provision in Dundee. Is that your position or stuff like that?
Yeah, thank you, Jim. I think that's really an important question, and you're absolutely right that staff, whether it's ward-based staff or whether it's community-based staff, have very little information about how this is all going to affect their working daily lives. I would certainly from the staff engagement sessions, and you know this anyway, just from being in the building, that staff's priority is their patients and their patients' families. That's what comes first. And certainly at the staff engagement session, it was very high emotions. People were in tears because they've looked after these vulnerable adults, and now who knows where everybody's going to get put. So staff, there's to be one-to-one sessions so that nursing staff and domestics and porters and everybody can understand what these moves mean for them. But there's little workforce planning being made available to explain how that's going to happen between now and November. Is that even achievable? Those questions haven't been answered. And from the community-based teams as well, we work really closely with all of our colleagues, and we can support families. We know that families are concerned about having to move out with Dundee, and what does that mean for the future? Because I think at the staff engagement sessions, it was made clear that what we're looking at is a contingency plan, but there are actually no long-term plans for over 65 psychiatry inpatient in Dundee. And that just to me is bamboozling. I do think that there are so many questions that have not been answered. And you get the feel from today as well. I understand the position, Dave, in terms of the IGB's roles and responsibilities. But I think you'd said yourself as well, Councillor McHugh, before, that surely the IGB's got a vision or a view on the standards of the commissioning services, where they're located, that there's input and a viewpoint on that. But there just doesn't seem to be any answers coming. And so on the back of your question, my question, as a member of the public, as a staff member and as a Unite workplace rep, it's really confusing to me how this can be a partnership, because obviously, Dave, you were saying at the last meeting, the NHS is doing an options appraisal. We'll have to wait. Nobody knows what's going to come of that. And literally 4 weeks later, it's announced that the building's going to close and everyone's moving. But yet you're the chief exec. You've got those roles, important roles in terms of the Health and Social Care Partnership and the IGB, but you seem to have no information about this, that it was coming. So the transparency and the accountability just seems to be missing.
Can I just add on the back of that? So obviously we've been in contingency at Kingsway Care Centre for the last 13 years, and we're going to be going into contingency again. So that means that any staff will be bused to Murray Royal and Forfar. So again, that's another substantial cost on transports on the NHS as well. Now, I believe that the building has to be, when they're getting, I believe they've known about this for ages, and it's been drip fed, and it's been like the closer's done. This could have been worked out better. The building itself has to be put back in the original condition. So the building's getting repaired anyway. So they could extend the lease. They could have repaired this years ago, because I've known about this for years, about the problems with the roof, which has then caused additional problems with inside the building. It's got to be repaired and put back to its original condition anyway. So the lease could be extended and the patients could be there, so they'll get the best service for the residents and tenants of Dundee.
Thank you. Can I want to go on to the, thanks very much. Siobhan, you've had your hand up for quite a while. Would you like to come in, please?
Yeah, thanks, Bob. A lot to unpick here. Listen, thank you guys for coming to the deputation, for coming as part of the deputation. I think that this is really important. I'm going to go back to the operational and strategic division, because I do have some concerns that they've not been, in my opinion, successfully kind of clarified. So I get the difference, and I think everybody, as Dorothy said, everybody gets the difference between the operational and the strategic, of which the IJB is part of that strategic overview. But my concern here is this, and I raised this at the last IJB meeting as well. If the operational process is actually producing a service that, in the opinion of many, will be detrimental to the care that we're expected to give, then surely as having that strategic overview, we should be entitled to ask questions and actually intervene to a certain degree. So there is a tipping point in that fusion and division between operational and strategic. My concern here is this, is that there is clear concern about the quality of care that will now come from this change. As us having control over that strategic overview, surely it's our responsibility to assess whether that meets the criteria that we would expect as that strategic overview. So there is things like the equality impact assessment has come up again and again, and there seems to be no real answers there. For me, those answers would allow us, the IJB, some consideration and some assessment as to whether that care will be impacted or not. So actually, as IJB, I would like to see that equality impact assessment, because actually, I think we need to assess whether the care is being, whether the level of care is being met. I would like to know when NHS Tayside actually decided on this as well, as a matter of, just as a matter of fact. I think we have hit a tipping point, not finished, but I think we have hit a tipping point here. There is clearly concern across the city, by the staff, by families, that this will have a direct impact on the level of care that has been done. I think for the IJB, we need to take that seriously, and we need to assess whether the service that we are strategically commissioning actually meets the level of care that we would expect.
Thank you, Siobhan. I'm going to wrap this section of item 6 up. I'm going to ask Dave. Dave.
Sorry, Bob. There's another question in the room.
I'll take one more question, and then I'll move on from this item, and I'll ask you to do something. Who's asking?
I'm sorry, Bob, but I actually, I mean, it might have been a rambling one, but I thought there was a question in there as to kind of where would that tipping point be between strategic and operational, and how we manage that at this point in time.
Well, that was what I was going to ask Dave to address, Siobhan, if that's okay, because there are quite a number of different elements to what's been raised so far. And well, I'm going to take this final question. Dave, is there a final question?
Yeah, thank you. Just more of a comment. First of all, a huge thank you to Elaine and Graham for coming along today. And I'm sorry, I've not got your name yet, but thank you.
My name is Lisa Copier, my colleague from Unite Union. We're part of the community unions. We are Unite Community, and we're here to support the deputation. As you can see, we're precisely in that age group that will be affected by that. And when we saw this happening, we were horrified. That's why just the two of us are here. But this is the unions putting down a marker. I think that message must have come across.
Thank you. Yeah, thank you for your presence today. And I think it's really important that we hear your opinion, the opinion of staff and colleagues. And it's just unfortunate. I think we're all a bit frustrated that we can't give you the answers that we want to in this forum. And I really hope that you'll get support to ask these questions in the correct places where you will get the answers that you deserve to have for the questions that you've posed today. My comment was really just to back up what Roger said earlier in relation to Dorothy's query about NHS board members, that absolutely correct, that this there are things that are board decisions and things that don't come past the board at all. This is an operational decision, so it's through executive team and chief officers, so there's not really any further helpful comments that us as non-executive board members here today could make towards situation. And around the quality impact assessment, Roger obviously couldn't comment on that, but it's something that's regularly done by executive teams and chief officers and going through the board. So just to tie up that little loose end there, that's all, but thank you.
Okay, and thank you so much for all the speakers so far. Dave, I think.
Oh, sorry, I have but one very last question, if I
Could you
may.
make it?
It's
Could you
for
make
the
it quick?
deputation. For the
Yeah,
deputation.
Okay, thank you.
Are you proposing to do a deputation to NHS Tayside Board, because it appears that some of your questions need to be answered there?
Yes, I think that's been undertaken by our NHS Unite colleagues.
Okay, thank you. Dave, can I just, finishing up this conversation, and firstly, thank you very much for the deputation who've clearly outlined what their concerns are and indeed their passion about this issue. Dave, you have different roles as well. You're an executive director for NHS Tayside as well. I think there are a number of questions that I think it would be really helpful if you could convey to the chief executive of NHS Tayside, namely the issues about the oversight role of the IJB in regard to matters such as this, but also the strategic operational point, and in particular picking up on Siobhan's point about is there a tipping point at this bit. I think that would be really helpful if we get some answers on that. The other part was about what advice has been given, not just to the IJV, but generally around some of these proposed changes, and also what is the status of an equality impact assessment around these matters. And I think the IJV would wish you to convey these to the chief executive so that we can get some answers for Dundee City.
Yes, Bob, I'm happy to take those all these issues that we've raised today. I'd like to thank again deputation colleagues for all their questions today, and back into an NHS side and discussion around that. And in terms of the that kind of distinction on the role for the from an IJB perspective around that, and again we can refine this further kind of with the meeting. Again, it goes back to the detail of the direction that we've given NHS Tayside in terms of the commission. So we need, from an IJB's perspective, we need to be able to be satisfied that sufficient arrangements have been made to deliver the POA services for the citizens of Dundee. And that's the kind of question that we put back to from an IJB perspective. In terms of the model, the contingency model that's been put in place, of course, it's been deemed to be clinically safe by NHS Tayside. So that's a starting point in terms of the sufficiency of the arrangements that are in place. But we can take that back and
thank you for that, Dave. And I think also it would be helpful if we could get some response. Clearly, we have our next meeting is not until October. It would be useful if in some form we could get some feedback on your discussions with the chief executive, and I'll leave that for you to determine how best and how quickly to do that. But I think we'd find that very helpful. Otherwise, we'll end up running into October addressing the same questions again. Thank you.
So, Bob, David Cheek wants to go into something.
Yeah, just I don't want to delay us any further, Bob, particularly. But again, thanks for your presentation. But bearing in mind what you just said about your colleagues that deal with either NHS Tayside or anything else. Graham brought a whole list of questions there, quite in depth and detail, and suggest that you provide these to your colleagues and could get them to have that in writing ahead of any future deputation to NHS Tayside's board. because you're not going to get answers on the day to these. You've just been presented to the board. At the board, it will be a case of like there's a deputation, but it's actually a statement you're making, and then the board can respond to that statement. They won't respond to questions on the day. It's a bit difficult for us here doing the same thing again. So just advise you get to do that in advance of all of that, seek questions before, and then you can present on that basis.
And I'm very conscious that you need to get this wrapped up, but just one comment on that is that Unite and Unison and the Royal College of Nursing Union are working together on this and asking all these same questions and getting no answers. So I appreciate your point, but for the minute, those strategies have been tried and failed so far.
Thank you very much.
Thank you very much.
Thank you, sir, and thank you so much indeed for your presentation today. And Dave, in terms of the item 6, do we want to continue to go through any further questions that may arise in item 6 on the report?
Yes, we'll move on to item 6, we're just noting this sort.
I know that Catherine is also leading on this too.
Yeah.
I'll keep it extremely brief. I think the report, both the covering report and the annual report, probably speak for themselves in terms of presenting a summary of progress and impact for services connected through the IJB, but also some of the challenges that the IJB's faced and how that has impacted both financially and in terms of workforce as well as areas of service delivery as well. So I'm happy to take alongside colleagues to take any questions on the detail of that. Other than that, all I would want to do is record my thanks. The annual report is a significant undertaking every year. I know that members are aware of that. So just to record my thanks to all my colleagues across the Health and Social Care Partnership who've contributed, particularly our colleagues in our data intelligence team who do a lot of work in the background on this, but also to members here who provided feedback on the earlier drafts and contributions that all helped to strengthen and improve the report, and some comments that remain for us to look at again next year in terms of the annual cycle of always trying to improve what we've done. But I think it's particularly important, and actually Technology Cairns who does all magical formatting, which makes it so much better than we would otherwise, and hopefully more accessible for the public. In terms of people to get a good overview.
Thank you so much, Catherine. As you know, we have real difficulty with the timings of this. Is that often that the IJV members aren't able to get sight of this at the right time, and there are clearly issues around that. But I do wonder, and Dave, I'm just thinking ahead to next year's annual report, as to whether we need to have the opportunity for I think for IJV board members to highlight the issues that they would like to see in the annual report, although they may not be cited on even a draft annual report. And I'll make that as a suggestion in my final year with the IJV, because I think it would help quite a lot to enrich the report itself. Are there any questions that people want to ask now about the remainder of the report?
Dorothy's got a question.
It's not a question, it's more a comment than a question. I'm grateful to Catherine for allowing us, considering the timing of the approval of this report, for allowing us to make comment on the draft, and that was really very useful. I think I said when we discussed this at the last meeting that I did find the report overly positive, shall I say, or at least much is made of the good and not so much is made of the bad, but then that's probably human nature. But I remain concerned as a member of the IJB on the timing issue, because it's not just this. There have been other things where they've been delegated for approval and haven't actually come, prior to approval to the IJB. So I think that's something we need to, have a good think about. I know timing's tight, Catherine, and I know you've got a lot of work on, the whole team, but it remains a concern to me. But I'm grateful we had an opportunity to comment on the draft.
Thanks, Dorothy. I think the only thing I'd say about that, that's not to take away from the underlying issue, because I agree with the difficulties around the timing, but most of the vast majority of that is driven by the national requirements of the legislation. We'll continue to advocate where we can through our national networks about the challenges that presents and the changes that would need to be made nationally to allow that at a local level as well. So please be sure that we continue to raise it too.
Thank you.
And thanks, Dorothy. And Dorothy, I share your frustration with Ken, and I would exactly share your frustration with this timing matter. Are there any further items that people want to raise with regard to item 6?
Yes, Bob, David, what's to come in?
David?
Yeah, thank you. Yeah, I'd like to just thank Kevin again for the opportunity in seeing the draft, first of all, before publication. That was helpful. I appreciate we're here today in the middle of August, and this document has been published on 29th of July. But we did have sight of it beforehand. On the aspects, I've been able to, it's a very detailed report and has a huge sum of information in there that, you know, you realise what the things that we've discussed out the whole year. When I go through the reports, I actually colour in red, amber and green. And there was a lot of green and good news in here, but significantly a lot of orange, which is the concerning ones. And so I hear what Dorothy is saying, but I had a significant amount of indicators in here where we were saying, giving the positive areas, but at the same time they were saying the struggles and pressure we're under to deliver on many local and indeed national indicators. But it's a very thorough document. We've used the word before, but I think I found it quite exemplary in the end. But as I say, it's done, it's dusted, it's filed, put away, and I need to move on and tackle the year ahead.
Okay, thank you. Dave, I don't think you need to respond to that. I think the statement's clear, unless you wish to say something.
No, leave it at that. Thank you.
Okay.
So.
Sorry, right, okay. I'm just going to say is that, Catherine, thank you so much for all the work that's gone into this report. I think there's a lot of good things in here. And I think there are also some areas that have been highlighted within the report for action. So I thank you for that and for all the time you put into it. I know this is a very difficult exercise. So thank you very much. This report is for noting, and we will now move on to the next item, which is item 4. Arlene.
I think Bob just pause for a minute in the room just to let leave the deputies leave. That's good.
Thanks again for listening.
Thank you so much.
Will actually be leaving the next deputy.
We're now on to item 4. As I understand it. Is that correct, Dave?
No, I've got a deputation request for item 12.
I didn't realise that was coming immediately after.
Yeah.
Yes. Steve, is that the case? We're now moving on to item 12 now.
Yes.
Right, I misunderstood that earlier on. So in that case, we can now hear the deputation from Food Train, and we'll have to go to item 12, which is the 25-26 budget and saving delivery progress update. Sorry about that. Thank you.
Thank you very much.
Sorry, I think it's over to Rosie.
Thanks. Thank you so much for inviting me along today and allowing me to speak. I'm Rosie McCluskey. I'm the Chief Executive for Food Train, and I've got with me today Bruce Headley, who is one of our trustees at Food Train. I'm going to talk to you again about older people, and you've heard that this morning already. But 12 years ago, Food Train was invited to Dundee because the council recognised there was a growing group of older people who could no longer access food independently. There was a need then, and my question to you today as an IJB is, what evidence tells us that the need has disappeared for that? Because when I look at Dundee today, I see an ageing population, increasing frailty, more people living alone, and growing pressure in health and social care services. If anything, I believe that need is much greater than it was before. I completely understand and I recognise the financial pressures facing the partnership. I know how difficult decisions that have got to be made around finances, and I don't underestimate how difficult those decisions are for you.
But before you make today's decision, I believe it's really important that you have the fullest picture of the people who rely on this service day in and day out. So following notification of the funding that may end, we surveyed our Dundee membership. For a membership of older people, many living with frailty, disability and dementia, we achieved a 51% response rate, so a robust data set. The findings were remarkably clear within that. 93% told us that food train is essential or very important to helping them remain independent. 79% said that food train is not comparable to a supermarket delivery, and 50% said they didn't know what they would do if the service ended, and 47% said they had no alternative. One member told us in the survey, "I would starve to death without it. I have nobody else and I am housebound." That isn't someone talking about the convenience of a grocery delivery. That is someone talking about access to food, and there's many more quotes like that. The report before you highlights that 87% of members said that they would continue to use food train if charges increased. That is true, but it doesn't also tell you alongside that 39% of that 87% said that paying more would cause them financial hardship or that they would struggle to afford it. Those two findings belong together. They don't need to be admitted from a report. People aren't saying that they can comfortably afford to pay more. They're saying that they find a way because they simply have no other choice. Throughout this process, Food Train has repeatedly been described as a simple shopping delivery service. I'd encourage you to look beyond that description. I've spent many a time sitting in our members' kitchens over the years. I've listened to their stories and seen firsthand how difficult everyday life can be when you become frail, you're living with poor health, or you have very little support around you. Not one of those homes I've left thinking that person just needs their shopping delivered. What I see are people trying to hold on to their health, their independence, and more importantly, their dignity. That is why it's important to understand what Food Train actually does. When we help older people access the food that they need, make informed choices, maintain good nutrition, and continue to live independently. Through regular contact, our volunteers build trusted relationships and are often the first people to notice when someone's health or circumstances are beginning to change. That means that we can raise their concerns early before their situation becomes a crisis. And one particular statistic within all of our findings is through our malnutrition screening programme, 28% of our Dundee members have screened are at risk of malnutrition. That's in 2026. Nationally, around 1 in 10 older people living in the community are estimated to be either malnourished or at risk of malnutrition. That tells you something really important, that Food Train isn't just supporting a typical cross-section of older people. We're supporting people who are significantly more nutritionally vulnerable than the wider population. If we are really serious about prevention, reducing avoidable hospital admissions and tackling delayed discharge and helping people remain independent for longer, then nutrition has to be part of that conversation because food is fundamental to health. I'd also like to make one point about our finances. The annual cost of delivering the Dundee service is around £191,000. Dundee DH&SCP contributes just under £89,000 of that. The remainder comes from Food Train through charitable fundraising and member contributions. For more than 12 years, that has been a genuine partnership. We have never expected the partnership to fund the full cost of the service. Every year we've brought additional charitable income, volunteers and community support into Dundee because we believe that we're working together to help older people remain healthy and independent. So today's decision about stopping Food Train's funding is therefore simply not about withdrawing £89,000. It's about losing £191,000 of a preventative community service that has been built through public investment, charitable funding and commitment to volunteers. Finally, I'd ask you to think about the future. There seems to be an assumption that the commercial shopping and online delivery have replaced the need for services like Food Train. For many people that we support, that just simply isn't the case. Many don't have internet access, Many don't have the confidence or the ability to shop online. Many people don't have family nearby. And even where the supermarket delivery is available, availability is not the same as accessibility. That's two very different things. A supermarket can deliver groceries to a doorstep. It cannot replace the practical support, the nutritional guidance and trusted relationships that help vulnerable older people remain healthy and independent. So my ask for you today is a simple one. I'm not asking you to ignore the financial pressures facing the partnership. I'm simply asking you to consider whether all of the evidence you need before making it, it's not just a decision about food chain, but it's a decision about how Dundee supports some of its most vulnerable older people in the future. 12 years ago, Dundee recognised there was an unmet need. Today, I simply ask you that. Has that need really reduced, or has it become even greater? Thank you.
Thank you very much, Rosie. Questions?
Chair, if I may, could I possibly just add a couple of comments? My name is Bruce Headley. I'm the Vice Chair of Food Train.
Thank you, Bruce.
I'll keep it short. Obviously, as trustees, our responsibility is both to the older people we support today and to the long-term sustainability of Food Train as a charity. Over recent months, I know we've explored every option available to us, including fundraising, service design, and charging, and we've always brought significant charitable funding into Dundee alongside public investment, and have never expected the DH&SCP to fund the full cost of the service. Our decision to continue operating on a month-by-month basis should not be interpreted as evidence that the service is financially sustainable. It reflects our determination to avoid withdrawing support from those vulnerable older people that Rosie has mentioned, and while every possible option is explored. However, we cannot continue indefinitely to absorb the loss from unrestricted charitable funds without affecting the sustainability of the charity as a whole. Therefore, the future of our Dundee base and all those older people that we support is clearly dependent on the funding decision that is made. Thank you.
Thank you, Bruce. Questions?
Dorothy's got one.
Nothing to the question or a comment, but I looked at the integrated impact assessment attached to the report. Very good report, actually, a lot of information in it. And the thing that jumps out at me is there are no positive impacts on the impact assessment. And that should tell us something. What impacts there are that are noted are either no impact or negative. So I think we should think on this one.
And thanks, Dorothy. And I wonder if we should bring in Christine. I wonder some of the questions might be asked. I'll ask some of the officers just to respond to Dorothy's point first, then I'll bring you in. Is that okay?
Thanks, Bob. I suppose the impact assessment is that tool that kind of sets out kind of clearly the implications for IJB members to understand before they come to decisions. So the quality impact assessment is our assessment of that position. So it would be up to IJB members to consider that in the context of the decision.
Well, thank you. Christina.
Thank you, Chair. Again, I suppose I just want to ask what evidence supports the view that the proposed alternatives can deliver the same outcomes for older people as the food train currently provides when we're looking at the report, and there was a 6 months review period. So what come out as an assurance to this board that this is the right decision from that 6 months review?
So, can I bring in Angie for that?
Yeah, thank you. I think they're all valuable points. I think what we need to remember, though, and keep in focus is that over a year ago, the IJB took a very, very difficult decision that we could no longer support practical supports for any citizens in Dundee. We had to prioritise our resources where they were most needed, which was around the social care element.
So we no longer provide practical support, including shopping service, for any other citizen in Dundee. These are, as much as it's a very valuable service and they do some really good work, this is still a very, very small percentage of the vulnerable people in Dundee, the vast majority of whom have already moved to a private arrangement with various providers. So there are providers out there that can provide a similar service, but it's contracted directly between the person and that organisation. Where we took some of the decisions around this, so although the Equalities Impact Assessment does identify that there are only negative impacts of this, there are alternatives that can deliver a similar service. Where the difference is that almost every partnership across Scotland, every local authority, already transitioned to those arrangements several years ago. Dundee was one of the last to make that difficult decision. And the typical kind of costs for that type of service, where it is arranged, is between £12 and £15. So the expectation is that the food trade will move to similar arrangements to make them more financially sustainable. Sure if that's answered everything you asked.
I think so, yeah. Bob, we've got David Cheap, wants to come in, so we'll finish up with Marlon.
Yeah, thank you. Thank you.
Thank you.
Thanks. I think actually Catherine picked up a lot of the points that I was aware from reading through the report. And although the impact assessments there, if you're going down there, you can put a cross against the box, whatever is fine. But reading the narrative on it, and there is a lot of mitigating factors put in the impact assessment report, and it harkens back to the really difficult decisions that the IJB had to take on the 31st of March of this year already, and this was one of them. So I appreciate there was a 6-month review period, but I think the report addresses that appropriately, so I'd be still supporting that.
Yeah, thanks both for the presentation. It was really useful around the point you're making about the impact that you provide a service to as a food train. My question is then, what's the impact then also on yourselves as staff for the food train and the people who volunteer and work for you? Because I mean, my understanding would be some of the people who obviously do the deliveries or do the stuff for you, that's also part of their kind of well-being sometimes, and their kind of supports and stuff like that. So it would be good for the board before taking a decision about knowing just, well, what did you see the impact on that being as well?
Yeah, can I answer that first and foremost, and then maybe Bruce would like to come in, because the board will need to take a decision whether Food Train decides to continue. Ultimately, we've got 4 staff that's employed within Dundee, and it may result in a redundancy situation for that if we decide that we're going to close. That will also result in the volunteers. We've got more than 40 volunteers that support us day in, day out. That'll be them out of that volunteering opportunity as well. So we're not just removing that. And I also would just like to respond around the cost involved around, I completely understand the finances are really difficult, but to expect an older person to be able to spend £15 on top of their shopping, it's really difficult. We're in a situation where older people are choosing between heating and eating. And we need to remember that as well, that £15 on top of something is really difficult when they're not getting that. They might not also be getting support within their pension availability as well.
Thank you, Rosie. If I may just add one point, I think there was a common misconception that this is actually just about doing a shopping service. I think for me, it's far more wider than that. The relationship that we have with the people when we deliver the work allows us to see early examples of perhaps malnutrition or distress or frailty. And I think for me, I understand the point around the financial decisions, but for me, there's also a key preventative part of this. As Rosie was saying, 28% of the people in Dundee that we have screened are malnourished versus 10% nationally. So there is clearly a concern in Dundee around the malnourishment of older people. I think just giving them the dignity to maintain time in their homes and therefore be better and healthier is an important part of what we do. But to Rosie's point, yes, I mean, if the decision is made that there is no further funding, then we cannot continue the service in Dundee.
Angie wants to comment.
Yeah, thank you. It was just to address the concerns around people's affordability for the services. So part of the checks that we did in 2025 when we made the original decision, or sorry, the original recommendations to the IJB, was around the use of disability benefits. So the vast majority of people who would struggle to go out and do their own shopping or carry out practical tasks within their home would have an entitlement to disability benefits. So part of any work that we would do to support individuals is about financial income maximisation to make sure that they are achieving those benefits. Those benefits are clearly outlined by the Scottish Government as for two main purposes. One is practical supports and the other is around attendance at social events and activities. So part of the thought process around some of those recommendations, and I believe that there are 20 individuals who have consented to the partnership supporting them to seek alternative providers should the food train make that decision.
Still more hands in the room for.
Thank you. I don't see any further questions from the floor. Can I therefore move to the recommendations therefore set out in 2.1 to 2.3, and that we note the progress to deliver the required actions and reviews in section 4 of this report. We instruct the Chief Financial Officer to provide a further update on ongoing and outstanding reviews no later than 31st of December 2026. And 2.3 approves the recommendation not to commission any further shopping or similar support services and confirms the intention to cease IJB funding to Food Train at the end of September 2026, following the 6-month review period as detailed in sections 4.3.9 and 4.3.10.
Bob, just
do we approve these recommendations?
Sorry, Bob.
Dave, where are we now? I've got to the recommendations instead. Are we asking any further questions?
Yeah, so I was going to suggest that we can move on to discuss the reports. We've heard the deputation on that particular item within the report, so I'd suggest we open up for item 12 for any other kind of questions from members before we go back to the recommendations, Paul.
Okay, so sorry, that's because I'm working at distance here. So are we asking the deputation to stand down now?
So there's no further questions.
What you're asking, Dave.
No further questions. There's no further questions for the deputation themselves. Obviously, the deputation are more than welcome to stay on the call while we discuss the important question.
I thought there were no further questions from the floor. That's why I moved to recommendations. Okay, are there further questions on this from the IJB members then?
Thanks, Bob. I'll pass on to Christine Jones to liaise on this.
If that's okay, yeah, because obviously the report covers, well, it does cover the food train aspect of it. It does cover far more than just the food train around that. But again, just like to pass on my thanks to Rosie and to Bruce for the comments and to members for questions around this. Yes, so this report is providing IJB members with an update around the approved savings decisions, service reviews and the financial recovery agreed in the 26-27 financial plan at the end of March, recognising that, as we've already highlighted, a number of very challenging decisions and actions need to be taken to ensure that we return back towards financial sustainability and make best use of the finite resources that the IJB has delegated to it. As you'll see in the report, good progress has been made across a number of the agreed work streams and service reviews. Details of these are provided through sections 4.2 to 4.9, and these are also summarised in Appendix 1 of the report in terms of the financial implications and expectations for this year. As we've already heard, and as noted in the recommendations, more specifically, members are asked to note the work that has been undertaken by officers with the food train as an organisation to support them to move towards financial sustainability without reliance on IJB funds. And also highlighting the alternative provision that continues to be available across the city, and the mitigating alternatives that are highlighted through the integrated impact assessment. So that's noted in section 4.3 and the accompanying IA. And to further improve the recommendation in 2.3 relating to commissioning intentions around any further shopping service or similar support, and to confirm the intention to cease this funding support to the food train at the end of September following this 6 months review period with the organisation. And members are also asked to note progress across the wider programme and agree that further update will be provided by December 2026. Again, happy to pick up any general comments or questions around the wider report.
David Cheap's Corporation.
Okay, just thanks for introduction, Christine, on this and the report. There is some, bearing in mind we set this budget earlier this year and the planned savings were identified. And I think at the end of the report is saying that we are forecasting for the end of the year that would be at this stage about 83% of savings. That's going to be a shortfall, I think about £2.1 million. So just bear that in mind. But where we have targeted reductions, and this report details quite substantially, I think it gives a good update on this. There are a couple of what I'd like to ask are risks still, because 4.4 on the external commission services, we have a plan for this year £1.7 million there, and it's reading the subsections that's not entirely clear where we are. And just after review, how much of the budget savings do we expect to achieve here is my first question on that. I'm not sure if that can be answered here or not, but that's one. Let me open that up. The second one was on the 4.9 on the charging and income maximisation review. And bearing in mind reading between the lines of the report, that looks like we're having difficulty with that in affordability for many users, whatever, and accordingly I see a risk to the 700,000 that may have been forecast there. So basically two observations, and the fact that I see we're looking up in the financial monitoring report that we obviously are at an overspend already after the first quarter, and now with a shortfall in potential savings, that we will have potentially an overall substantial risk in over expenditure at the end of the year, and the impact that has on NHS and council as well.
That's fine. So in terms of the commission services, all the providers have had notification around the funding available for them for this year, and that's been implemented in terms of our payments to them. There are some ongoing conversations specifically with individual organisations around the how that's going to maybe change some of the contractual specifications and their delivery capacity. So that side of it is perhaps still ongoing between contract officers and contract leads and the providers themselves to manage that. In terms of varying degrees of how that's going to be delivered, but most of that is being implemented and delivered. We do have the wider strategic commissioning review that we undertaken with providers through the autumn, which was sort of ancillary part of the budget setting process. So that will be looked at and that be considered as part of sort of future commissioning intentions and delivery of opportunities for sort of delivery of future budgets position and efficiencies there. And the second part around the income maximisation, yes, that probably has impacted. We've had some challenges around that. We've made some very significant progress around maximising some of the income and reviewing some of the charging. As you could possibly be aware, charging decisions themselves are actually delegated or retained by the City Council, and the actual mechanisms around the systems and the recovery processes involves far more than just health and social care partnership staff. It involves a number of our teams within the council. We do have a number of meetings and progress and mapping pieces of work right across the whole system, from the initial conversations with the service users who are moving into a chargeable service, the communication with them, the ongoing billing, and then the recovery that crosses a number of different teams, and that's just through system IT and debt recovery parts of it. Then some of that has taken possibly longer, but we are making some good progress around a much better collective understanding around the wider system, and ensuring that that we get the right communication to service users as early as possible, and the right information onto systems to manage this, and where individuals have not, for whatever reason, have not been able to pay the bills that they are receiving, then that support through our welfare right team within the council to look at their own benefits assessment and financial eligibility for benefits, to make sure that they are actually maximising their own income to manage the affordability of that, and also through debt recovery to contact people at early opportunity to stop bigger bits of amounts of debt building up, then becomes unmanageable as well. But there's a lot of good work that has gone on, and we're starting to see some of the things actually fall into place as well. Does that answer the?
It's fine. Thank you. Thanks.
Dorothy?
I think David covered most of what the comment I wanted to make, and Christine's given a very full response. My main concern was I saw a number of challenges here in how we were going to achieve you call them savings, I call them cuts, that we agreed. I didn't agree, but the board agreed at the budget. So we'll see how that goes as the year plans out. And I just want to throw into the mix here, it wasn't really helpful when, because of timing of the different budget setting processes, we ended up, didn't we, with another £1 million, I think, adrift, because what we had expected from NHS side did not actually appear at the end of the day. And that's a concern for me as well. That's just like having reports being delegated for approval because the timing doesn't fit with the IJB's meetings. This is another thing. The budget timetables, are not conducive to real discussion and open and transparent governance around budgeting.
Colleagues, got a question?
Yeah, just first of all, on the back of Dorothy's thing there, I think we discussed previously about the £1 million saying that it didn't come to fruition from NHS side. I think the agreed amount did come from NHS side, but it was just used to backfill another deficit that was unexpected. So the agreed amount did actually come from NHS side. That's been changed. They didn't say they were given an extra month and taken it away. It was just used for a different purpose. But yes, my questions. So the progress report is really helpful to have this and just see where we are currently. First of all, there's a couple of really positive things coming out of this. I was really pleased to read about the physio and OT efficiencies being identified. I think that's brilliant, and see that we're on track and we can make changes there that flag a couple of positive financial savings as well. And good to see the admission also about the low cost equipment and adaptations, understanding that for a relatively small amount of savings that it wouldn't be worth it as far as the impact on people, because this can have significant impact on people's lives and reduce the wider system demand overall if we do provide this support to people. My question is around 4.7.4. This was around the weekend working. And it states that under the organisational change policy, it's recognised that some staff may have been entitled to pay protection. However, we're still going to be ceasing the weekend service from the 2nd of November. So I'd just like to understand in real terms, what are we doing here? So we're going to cease that service on the 2nd of November, but we can't change the pay that we're providing to staff with the pay protection. So are we still going to be paying as if we were having that weekend service, but not actually providing it to people?
Yes, so obviously the IJB will have to make a decision on the actual service delivery around the weekend service to realign that with other aspects of service delivery, feeling that the recommendations based on the fact that the delivery at the weekends didn't see as many people as perhaps it justified in terms of the cost, and those staff were actually being redeployed during the week to the more busier times. Yes, we absolutely understand that under the terms and conditions for individuals, they do retain an element of protection under organisational change. That will be managed within the budget side of things, and that, as do changes of individuals through applying for alternative jobs or anything else, then that protection stops when they move on to other things under the organisational change. So that will not necessarily be permanent long term, and that will also be managed as part of the internal staffing arrangements within the team, in terms of how the costs and the staff are managed, but it will be rostered more to Monday to Fridays, where the busier times in terms of the demand are coming through.
Okay, I still have concerns that we're still paying, we're not saving anything there because we could still be providing the service for people, but because these staff, they may choose to go and find employment somewhere else, but they may also choose to stay here for another 10 years and we're still paying them to do a weekend service, but not actually providing that for people. So I just don't quite see how that equates to anything positive.
Yeah, I think, I mean, that's, you know, from a financial perspective, that remains a financial risk because it is depending on turnover of staff, and you know, people choose to stay in that, yeah. There's a residual financial cost to part of the partnership to manage within the overall resources and within that sense. Ravens, what's going on? Sorry, I
just wanted to add that although short term, you're right, the financial savings will not be achieved in short term. However, productivity will be up significantly, and that's likely to have wider savings within the wider system because of the knock-on effect. It's not going to be as transparent, and then it will take us a little while to achieve the actual financial savings we can show on paper.
Yeah, and we highlighted this when it came in. This is an operational service delivery side why it's in a budget, because you know what's supposed to be these are long-standing teams, they're well established. The staff don't regularly move quite frequently, so therefore, yes, long term, they will retain their protections. So, I mean, other than people retiring or to natural waste, that kind of thing. And then you can immediately resource will go into Monday to Friday away from the teams. But there is an additional impact on the other teams that do operate out of hours during the week and the weekend. I mean, and that's elements that the staff have highlighted themselves to the manager, and as I said in the paper, they're progressing to a date that will change. But there is an impact on other services. What you said when it's came in for the budget that you're not going to say money's back from this. It's quite a relatively small money there for the next few years, I would suggest that at the very least.
Bob, I can't see any more questions in the room, so back to yourself.
Okay, thank you. And I don't see any other questions online either. Can we, thank you for that, it's been quite informative. Can we now move back to the recommendations that I read out earlier on, and 2.1, noting the progress to deliver the required actions in section 4, 2.2, instructing Chief Finance Officer to provide further update and outstanding reviews no later than 31st of December 2026, and 2.3, approving the recommendation not to commission any further shopping or similar support services, and confirms the intention to cease IJB funding to Food Train at the end of September, following the 6-month review period as detailed in section 439, 410. Do we approve these recommendations?
I don't agree with 2.3.
I remove
Dave,
the
you have to tell me what's happening in the room.
Councillor Hughes has indicated she's not supportive of item 2.3. So that is.
That will be appropriately reflected in the minute.
Sorry, I missed that, Roger.
That will be appropriately reflected in the minute.
Okay, thank you very much indeed, Roger. Thank you. With that, we can now close this item and move on. I suggest that we take a 5-minute break just now.
Yeah, I think it'll be well from the meeting. Thanks a lot. Thank you.
And I'd like to thank Rosie and Bruce. Thank you so much indeed for coming today.
Thank you.
Thanks a lot.
Very well, thanks everybody back in the room if you want to reconvene the meeting.
Okay, then, thank you very much. Arlene.
Okay, so that now takes us then on to item 4 on the agenda, which is delivery of primary care improvement plan annual update, and I have this for a decision.
Thank you. And I believe we've got David and Gail on this one. Thank you.
Thank you very much. I believe Dr. Shaw's had to leave to chair another meeting, so I'm afraid you have myself. I'm Gail McClure. I'm part of the primary care team in Dundee Health and Social Care Partnership. The report is the Primary Care Improvement Plan, and it's the annual update. Seeking for the implementation plan from 25-26, and also seeking approval for 26-27 implementation and proposed funding. Taking some of the key points, the spend has increased year on year over the duration of the Primary Care Improvement Plan, and in 25-26 the spend was £6.04 million. The projected spend for 26-27 is sitting at £6.55 million. As the increase in costs, increase in funding has come through, teams have tried to continue to develop the services to meet the needs to support general practice. In terms of our background to this, the primary care improvement plans were introduced following the implementation of the GMS 2018 contract. There are 3 areas that are regulated that we're required to provide. Those are for vaccinations, for pharmacotherapy, and CTAC services. The other 3 areas are those that are nationally agreed priorities relating to urgent care, in our instance, mental health and first contact physio, and primary care link workers. In terms of 25-26, key points to note in terms of progress: the vaccination transformation programme is fully implemented. All vaccinations are delivered out with general practice. In terms of pharmacotherapy, for the first time we've made a significant step forward to recruiting all pharmacists, and that will enable us to transition towards technician managed hubs and release the pharmacists to be able to undertake more senior skilled work, which will be beneficial to practices and to patients. In terms of CTACs, it's been a demanding year. They have had to take on new pathways looking at phlebotomy for children and young people, which necessitated a significant amount of training to upskill the staff to take that forward, but that's now working very well. They also saw a significant increase in demand following the introduction of a new diabetes pathway, which followed reshaping of diabetes between secondary and primary care. That's now implemented more fully, but what it also led to was some practices taking a decision that they would do less in-house phlebotomy and more that would be undertaken through CTACs. Urgent care continues to deliver the services to the care homes in Dundee, but the team have also worked on a wider basis to look to see what they can do in terms of supporting early intervention, focusing on frailty and trying to support prevention of unnecessary admission, and that continues to be work in progress. One challenging area has been for our PAMs, the patient assessment service, where they've had vacancies for a significant part of 25-26, and the impact means that we've been unable to release the GP capacity we would expect, because this team would normally see the patients the first point of contact. Unfortunately, because we've had the vacancies, that has then defaulted back to GPs. So patients are being seen, but it's not releasing the GP time that we would envisage. And we're hoping that situation will improve during the course of this year. Last year, in terms of our primary care link workers, we actually were able to fund for a fixed period of time an additional associate practitioner, and this was invaluable in trying to manage the waiting list and actually reduce the waiting list and removing it completely. Another evolving situation in 25-26 was a recognition that CTACs were actually receiving a number of requests for phlebotomy from secondary care, and it is recognised that from a patient care perspective, it would be far better for patients, whether they're coming for primary or secondary care phlebotomy, for that to be done in the community. And that is being taken forward slowly under an agreed project implementation plan with a board looking at how they can integrate community phlebotomy going forward. Plans for 26-27. We need to continue to closely manage both the delivery of service and the financial portfolio to try and make sure we can maximise activity and capacity. CTACs continue to see increasing demands, and they've also had a number of challenges through digital and premises issues that have impacted on their capacity during the course of the year. Those are being worked on at present, and also the team are taking what steps they can as well locally to try to make sure that they can maximise the capacity available to them within resource. Such things as the appointment of a short-term stock control post to free up clinical time, and also to ensure that we are carrying the right amount of stock and not unnecessarily holding stock. In terms of PALMs, the primary direction of travel is to try and get the service back on a stable footing through the recruitment to the vacancies. The vacancies have arisen and we haven't been able to progress recruitment due to organisational change happening within NHS Tayside. We have now got approval to move forward on 1 permanent post and 2 fixed term posts, but obviously our objective would be to try and progress all recruitment required. In terms of the vaccination transformation programme, vaccinations nationally have started to drop, and one of the focuses on priority for the vaccination team was to look to see what can be done to try and improve the uptake both of children's and adult vaccinations over the period. The teams are also, though, starting to develop their service by making sure that every contact counts, and that's a programme to try and take the opportunity when you have a patient in front of you to be able to signpost them. For example, potentially if they're thinking about smoking cessation, to be able to have that not informed conversation, but just that very brief intervention, and offer opportunities for patients to look at taking forward their own health. One area that we do feel needs work in 26-27, specifically highlighted with First Contact Physio, is to gather more robust patient feedback. At the moment, we do get feedback through care opinion, but that's fairly sporadic and not consistent. And a number of the teams are looking at opportunities they can have to try and engage with patients so that we can factor in patients' needs to any further developments of service. I appreciate that's a whistle-stop tour around the report, and I apologise. I've tried to pull out what I think would be the key points, but if anyone has any questions.
Thank you, Gail, and actually you've done pretty well given the size of the report, so thank you so much indeed. Okay, questions, please.
So what Dorothy in the room?
Okay, Dorothy.
My question relates to PALMs. The plan under completed actions tells us that, says maintained maximum PALMs provision, and yet the governing report at 3.7 and 4.2 speaks of inequity of care across Dundee, so I'm a little confused.
So I will
maximum PALMs provision or inequity.
So my poor wording, and I apologise. So the PALMs provision at the moment, the service is being provided to 17 of 21 practices because they've redistributed to make sure that as many practices can have access to PALMs services. The service is a patient assessment service. So the inequity is coming through in terms of the support that's being given to general practice, but the patients are still being seen. The fact is that it's a GP appointment that's been taken up to see the patient rather than a PALMS appointment. And it is just an, I'm sorry, using the wrong word there, it is an assessment service. It's not ongoing treatment and care. So I perhaps poorly worded that, and I can understand that why that appears contradictory. Apologies.
That's okay, thank you. Understand.
Okay, thanks, Nicola.
Thank you. I would like to make just a couple of positive comments from a service user perspective. For contact physio, excellent service for triage, what to do, what not to do, etc. So staff absolutely fabulous there. Know many people who have used that service and are really satisfied with it. Getting it more widely known, I've spoke to many people who don't know about the service either. So that's an ongoing process, isn't it? But yeah, an excellent service. As far as CTAC goes, and I know that in the report that there's issues with waiting times because demand has gone up. So this is waiting times to get the telephone answered. And yes, absolutely, from a service user perspective, there has been that, waiting over 20 minutes for a telephone call to be answered. However, in context with that, there's clearly been some improvements because more recently, done and dusted within 1 or 2 minutes, appointment given. So that was unexpected and very positive. And what I would like to point out there as well is any time that I've personally spoken to any staff making appointments, they are exceptionally patient, with getting you the right place and the right appointment that suits you. So please do pass that on to staff. It's unfortunate about the PALMS situation with recruitment, so I'm really pleased to see that that is now going to be progressed. And I do note that the positive feedback, even though you've been only able to deliver a basic service, that there's really positive feedback noted, from clients that have been using it. So again, do relay that on to staff that you shouldn't be demoralised by the gap in the service. Recruitment, it's now progressing and people really appreciate it. So thank you for your report, and I don't have any questions, but I thought it was important to make those comments to you. Thank you.
Thank you very much. I will take that back to the teams because they have felt very under pressure, particularly PALMS, and it can feel very challenging for them. So I'd be delighted to take that back. CTACs, there has been a recent improvement. There was some fixed term posts that have been put in place for a short period of time, which have helped the situation. The problem is they are fixed term. We're looking at what options we have to try and maintain access through other things. Emailing is one system, but that's not efficient and not effective, and not particularly good for patients to have to go back and try and email. So I think there are a number of things that we need to consider in the future, but it's good to hear that positive experience being fed back. Thank you.
And I just add one more point that I forgot to say, and thank you for mentioning the online meeting, because I do think that that's a good avenue of choice as well. You mentioned the community phlebotomy service, and I know in the report that there's been a project initiation document and a board set up for that. Can I just quickly comment that, when you're getting your bloods done in 9 Wells, yes, it's a drop-in service. It's not the best environment, of course not. They're very, very busy. You get seen very, very quickly, very efficiently as well. And it's drop-in. So I would like to see that in the community as well. I would really like to see that, considered rather than everything by appointment, because certainly the busyness in the 9 Wells department has, is evidence that that can actually be achieved. So I would like that considered. Thank you.
Okay, thank you for that. That's those ones of support shall record gratefully received. There's no more hands in the room, Bob.
There are no more hands, right? And I don't see any online either. Thank you very much indeed, Gail. That's been really helpful, and I'm glad that members are appreciative of the services that are provided. I think that's very good feedback to the staff. There are 6 recommendations under 2. Do we approve the recommendations that have been submitted?
They're approved.
I take it that, is that okay, Dave?
Yeah. I'll look at that.
Oh, okay, thank you. The recommendations are approved. Thank you.
Thank you very much.
Thank you so much in detail. Arlene?
Bye-bye.
Yes, takes us now on to item 5, reducing harm from drug and alcohol use update report. You have it for a decision.
Welcome, Pamela. Nice to see you again.
Good morning. Thank you very much for having me around the table to present this report. Hopefully for the time you've had to read through the report, you can see the kind of focus and progress that the ADP feels it's making. However, I would caveat that in that we're not complacent about the size of the challenge that we are facing locally and also nationally in terms of drug-related harms and alcohol-related harms. So it's caveated in that context. I probably want to bring to your attention just a couple of things from the report. A residential rehab pathway was evaluated externally by researchers who have also looked at others in the country, and we had a very positive output from that in terms of the quality of that pathway, the experience of individuals and their families in going through that pathway, and a really nice summary of the kind of clear aspects or qualities that you would expect to see that make it positive for people. So a good benchmark for us there. One of the things that we are going to be doing with ADP members, and it may be something that other people want to understand better, is just, you know, what that assessment process looks like, because we definitely in the ADP had a debate around people who are in crisis, and generally residential rehab is not used as an option for people in crisis. So I think there's something about understanding how decisions are taken and how we try and maintain that good output for people. Our MAT standards, we continue to do well and have positive feedback on them. You will notice a slight difference in the report for MAT, where there is a kind of lighter shade of green, a provisional green it's called. The reporting criteria for MAT standards has been altered slightly, I think pretty much in response to the national portfolio or presentation of drug-related deaths and non-fatal overdoses. And so that change does not reflect a reduction in our performance, but it does ask us to think more about that harm reduction pathway in particular, and with a focus on Hep B and immunisation for people. And I do think that's an area where we will look deeper at that, because there are thoughts about how improvement could happen there. We are just in the throes of finishing off our revised delivery plan, which goes to the ADP next week, and is just in its final draft. And that seeks to really do two things. One, be very clear about the priorities for the ADP, but also to acknowledge the wider system aspects, the integrated public protection aspects, where some of the work of the ADP will be captured in a more joined up way. From a national perspective, there is, there have been a few summits, and they have been mentioned, but probably not fully in the report because they're more recent. But I think our report really does reflect the right areas of interest, such as for alcohol, the timely response for people who need care and treatment, but equally the prevention aspect of alcohol brief interventions, which nationally has lost its profile and remains a very strong treatment or intervention that has a very strong efficacy. So that's something we're looking more at again. And from a drug side of things, the non-fatal overdoses and those known to us, particularly those going through 9 wells, and our drug death stats. In that harm reduction space, I think, as it says in the report, we have a very comprehensive suite of interventions and treatment services and access services, perhaps a couple of areas where we're hoping we can make a difference. One is when we have the drug checking service fully operational, and that will allow us to see what's in drugs. The assertive outreach, I think we definitely believe that there is more to be understood and done in that side of things, and we're exploring that at the moment. And we were also successful in the digital lifelines bids this year, so we have funding to bring digital capability for people to use in the harm reduction pathway, the women's pathway, and the residential, all with slightly different slants depending on where individuals are at. And I would emphasise this is not about giving people phones, this is about giving people capability and support in the same way that all of us do in terms of using digital capability to live our lives. The second part is the annual report survey that we have to do, which is a bit of a self-assessment. I think one of the things I wanted to draw out from that, and that does require sign off by yourselves. We had to submit it in draft to keep with the timescales, but we require your approval. But one of the areas that I think is really important, it sits alongside lived and living experience and trying to make sure we get that voice as loud as possible, but also family involvement. So drug and alcohol death reviews, the suggestion or the requirement is that we would have family involvement in that, and we don't. So we are exploring, we're not alone in that, we're exploring how you would do that. And it was very interesting at the National Drugs Summit when families were speaking about some of the views on that, which is that we would, some of the professional views is that we would re-traumatise people. And the family feedback is that that is a very paternalistic and not a view that is commonly shared by families. So there is probably something about understanding that better and how we do that, but certainly to be considering it as something we have to take forward. So I'll stop there, and I'm happy to take any questions. Thank you.
Thank you so much. Questions?
David Cheap and then Dorothy.
Yeah, thank you very much for that presentation. I think I'd just like to actually, note congratulations to the Alcohol and Drug Partnership for the work. When I look through the detail here of the medication-assisted treatment standards and see the progress that's been here, which I really wasn't aware of, and it's been really good focus up here, the progress since 2022 right through to how well it's standing in 2026. It really is to be congratulated, I think, and the fact that we continue to offer very rapid access assessment to assistance here, which the report shows, again, should be noted. I think it's a positive report in light of, we know of continuing and growing problems, but they seem to be getting faced head on. So I just like that. I think that's worthy of note.
Okay. Dorothy?
I'd echo David's comments. This is a good report. I know it's a huge problem, but it does look like there's good work going on here. I have a couple of little questions. The 4.2.12 talks about residential rehab. I should probably know this, but is this the alcohol and drugs service? Residential rehab, is it provided?
Yes, it is.
Yes, okay.
It is.
And the one question I have is the 4.2.14 talks about funding challenges and gaps. And it says it's a challenging financial context. And I'm wondering, will the IJB be kept up to date? Will we receive updates on this as time progresses?
So I can one question, questions leading the commission for the ADP.
So yeah, I sit on the ADP as well, and with the commissioning group sits under the ADP in terms of financial monitoring. We, the ADP across Scotland, the ADPs received an element of funding from the Scottish Government, along with the sort of the national framework around how that needs to be utilised, bearing in mind obviously the sort of local priorities and local reflection of that as well. The funding has been continued into this year, although it is flat cash, with some small uplift funding for for some elements that are directly linked to staffing pay. So there's, again, correct the wider IJB's position, there's not additional funding for additional investment or additional growth. So we do continue within the ADP to look at where the priorities are, where the national targets and priorities are, but also where the local needs are as well, and continue to work with within the ADP to manage that. The ADP funding is actually embedded within the overall IJB's financial position. We manage it so that the local that national allocation funding is not overspent. But actually part of the IJB's reserves may reflect some underspend that we carry forward on behalf of the ADP as well. So that it is closely monitored and scrutinised. But in addition to that, then the wider IJB's funding that we actually have, there is core services around sort of drug DDARS team, drug and alcohol services, and wider commissioning services as well that actually support the work that the ADP do as well. So we do continue to very closely scrutinise and monitor and report through ADP, and if there was a sort of financial implication around the strategic priorities of the ADP and the wider IJB, then again, that would be highlighted back to IJB as well.
Okay, thank you, Christine.
I'd see any more hands in the room, Bob.
Thank you very much indeed. We have recommendations set up 2.1, 2.2 and 2.3. Do we approve these recommendations? Yes. Pamela, thank you so much indeed for your presentation and answering any questions today. Also, I want to thank you for your leadership in this work. I think we all appreciate it in Dundee City. Thank you.
Oh, thank you very much. It's a pleasure to be contributing. Thank you.
Arlene.
Okay, so we've dealt with item 6 on the agenda, so we'll move on to item 7, which is annual report of the Dundee Health and Social Care Partnership Clinical Care and Professional Governance Group 2025-2026, and you have it for noting.
Thank you. So
I've Jane Smith on this. Is that
yes, I'm going to speak to this one because Matthew's off. Yes. So taking the report as read, sort of highlighting 3 key messages. Throughout 2025-26, the Dundee Health and Social Care Partnership Clinical Care and Professional Governance Group provided a reasonable level of assurance, and that assurance was accepted through NHS-TSA's clinical governance arrangements, demonstrating that governance, risk management and assurance systems are operating effectively. Workforce continues to be one of the main challenges across the partnership. However, there's evidence that mitigation actions are having impact, with staff continuing to deliver high quality clinical care. Despite increasing demands, financial constraints and other pressures, services have remained resilient, with positive progress seen across a number of areas, including the drugs and alcohol services, service transformation and organisational learning. And those are 3 quite key points. Happy to take any questions in respect to this report.
okay? Any questions in the room?
I don't think we've got any questions in the room. No hands up. No.
Sorry, Dave, was that no questions?
Oh, so no questions in the room, Bob.
Okay. Any further questions before I move to recommendations?
No.
Okay. The recommendations that I have to scroll up to find them. Right, there are in 2.1, 2.2. So we note the content of this report, and we also note the work undertaken by Dundee Health and Social Care Partnership, etc. And thank you very much indeed. Thank you for that update. Very informative. Thank you. Next.
So now on to item 8, Performance and Audit Committee Annual Report 2026. You have this for a decision.
Thank you. So I'll pick this one up just now. So this is the annual report providing to the IJB and the details of various reports that have been presented and scrutinised at Performance and Audit Committee throughout 2025-26 on behalf of the IJB. Section 4.4 includes a table with the list of the regular, the annual and the ad hoc reports that the committee has received, and also within the section 4, there is details around the responsibilities and terms of reference around the Performance Audit Committee. So the report is fairly brief, fairly self-explanatory, and it recommends accepting a level of reasonable assurance for the IJB on behalf of the work undertaken by PAC during the year.
It's amazing what audit can do. Thank you. Dave, any questions?
Dorothy's got a question.
I'm not sure if it's a question or comment. I'm looking at the table, which tells us what we looked at in each meeting. And the shaded column was where the adjourned meeting that wasn't quorate. I see 19th of November, and then there was a special meeting on the 26th of November. Was that to take account of what should have been discussed on the 19th of November?
So the meeting, I just noted the date wrong, actually November 25, in terms of the special meeting.
So,
yes, we were not quorate on the 19th. We had to adjourn and that meeting and defer. Obviously, a hastily arranged meeting was sorted out for a week later because we did have a number of pressing position reports to be looked at. Namely, the main one was the annual accounts need to be signed off by the end of November as well. But again, it was a shortened meeting the following week, and therefore a number of things had to be deferred and they were taken into the February meeting as well. So it was highlighting that these reports were shared in advance of the meeting. They were published and shared, but we never got a chance to look at them until then. Some of them in February, but some in the
Can I ask then when we last looked at the strategic risk register?
Me.
Yeah, it was a May.
May.
Again,
Performance Audit Committee, and that's been at the IJB as well.
because this got a lot to it. It's 25, 26, so it comes on.
Right, okay.
Thank you for that. Are there any further questions, Dave, in the room?
No, nothing else in the room.
Okay. As well as chair of TAC over the last couple of years, I just want to thank everyone I've worked with, both with staff and with audit. I think it's been quite a productive relationship, and I've also taken the opportunity to have informal sessions with them as well, just to understand the background a bit more, and it's been really helpful. So thank you very much indeed. So moving to recommendations, so we note the report, and we also do we accept the reasonable assurance provided in the report? I take it that's a yes.
Yes.
Okay. Arlene.
Okay, item 9, Public Bodies Joint Working Integration Joint Board Scotland Amendment Order 2025. You've got this for a decision.
Okay, Catherine, I think you're leading on this.
Yep. So this report provides an update on the implementation of the Public Bodies Amendment Order. I'm not going through its full title, sorry folks. So the key change is that from the 1st of September 2026, lived experience members, so that's third sector, service user and unpaid carer representatives, will become voting members of the IJB. Obviously, this is a really important development and a part of the kind of evolution of the governance arrangements for IJBs across Scotland, and reflects a national commitment in terms of strengthening participation, co-production and inclusive decision making, and making sure that the voice of people with direct experiences, services and caring responsibilities aren't just heard as they have been at this IJB over a number of years, but also are now able to contribute equally to that formal decision making process and voting within the IJB. So the report sets out some of the practical implications for Dundee IJB to consider, including some of the technical changes around the quorum arrangements and updates that will be required to the standing orders, but also wider arrangements around induction, support, governance, and the management of interests of individual members. So I suppose what that is trying to say is that although this does require technical changes to voting arrangements, it's also an opportunity for the board to strengthen its culture and inclusion of lived experience voice and how that's done meaningfully. And I think it's also really important to take the opportunity to acknowledge the valuable contribution that our current lived experience members already make to the work the board and have done over a number of years. Obviously, the process of implementing this has been kind of instigated by the new amendment order, but much of the kind of considerations would apply equally to all of our board members, and we're fortunate to have very experienced lived experience members who have a lot to contribute to the process themselves, as well as that being supported by officers. Roger has role as the clinic and standards officer and others as well. So looking forward to working with them on that in anticipation of getting our final statutory guidance from the Scottish Government, which we await with bated breath at this point in time to help us to get some of the formalities in place.
Thank you so much. And I'd just like to reiterate that point that Catherine made in thanking existing user and carer reps and the independent sector. I do think that, and the third sector, sorry, I should say, because it's actually really more than just appreciate that work. I think it's vital to the ongoing work that we do. And I think, as the report clearly states, this is more than just about voting rights, it's about a whole participatory approach. So thank you for that. Any questions?
Yeah, and then we've got Colleen then David.
Yeah, thank you. Yeah, my question kind of relates to agenda item 4.8.5, which is I'd like a bit more assurance that we have the support in place for who will be our new voting members to support them through the possibility that there may be undue external pressure on them from bodies that they may represent currently, as they're going to have to be acting with the interests of the IJB as a whole in mind. So we're all aware of that in the room, but I just wondered if there was extra support or extra communication, suppose so that these members aren't having to kind of defend themselves against any external pressures. If people are, you know, thinking that they should be representing only the area that they are usually representing.
Yeah, I'm happy to comment on that, Bob.
Yes, I screen through all the time. Please go on, Roger.
Yes, I could confirm that the same way as any other member of the IJB will be in a position to reach out for advice at any point. Lived experienced members will obviously have that same facility. I'd like to think that for the years we've provided a helpful and supportive advice service for members. I don't think it's a good idea to anticipate in advance the issues that might arise, because they may or they may not. But I know that Martin, I know that Nicola, I know that Christina will be able to get in touch with the officers and will support them in any way we can. What we've tried to do here was just to bring to everyone's attention, not just the members within the room, but the press and indeed the public, the role that the lived experience members will be playing, and I'm sure that will be expected.
And just a comment to, yes, very excited to welcome them all on board, because as Catherine said, we're very lucky to have very experienced people within here.
Okay, I have Christina. I'd quite like to take Christina first, and then we'll take anyone else in the room if you don't mind, Dave. Christina.
Yeah, thank you, Chair. Just to really say that we're looking forward to becoming voting members, and that Martin, Nicola and myself have been meeting regularly. The third sector interface have a network of provision and learning sets funded by the Scottish Government to help us prepare for that position of our duties, and we've been in contact with Roger and Dave as well to look at some meetings, informal meetings around standing orders and others. I think, the new members coming into Dundee specifically, I've chaired the IJB before, I've been an executive director, and Martin and Nicola do have experience in representing as well, but we're assured that we've got that support, and we're certainly not frightened to ask any questions as well. But yeah, we're looking forward to it.
Thank you, Christina. It will be lively, I can guarantee it. Further questions?
Okay, and then we've got David, Nicola and Jim.
Personally, mine's just really for clarification and with avoidance of doubt. So this is to be mid-1st September. And bearing in mind I think our next meeting of the IJB is 21st of October, will the lived experience members have voting rights at that, or will there have to be some form of formal paper proving post 1st September before they then have active voting rights, or is it implemented automatically living brothers right 1st October?
Happy to answer that, Paul.
Yes, please.
Voting rights will be conferred as a matter of law with effect on the 1st of September, so no approval will be necessary. What I have, however, had to guard against was the possibility that there is a special meeting of the IJB before we're able to discuss the standing orders and make sure that they are approved. So if there is a meeting after the 1st of September, but before the next scheduled meeting, there will be an item for approval of the standing orders. Not that the approval of standing orders is required to confer voting rights, but because we will need to have standing orders before the formal business commences.
Thanks, everyone. So as a service user representative, the first thing that I would need to say within the report on section 4.3, as a member in respect of service users residing in the local area, and it is better explained in 4.85 and also the advice note from the Standards Commission, which I think should be circulated to the board. It offers better clarity about what the service user role really is. Service users residing in the local area might actually imply to someone that I personally representing service users across the whole of Dundee, and I can assure you that I am absolutely not. I will share my own perspectives and experiences and those of others that are appropriate, and I'll make that clear within every meeting, as I have done previously as well. There are some comments here today that would have been useful to know prior to today's meeting, specifically in regard to a special meeting of the IJB to discuss this further and the standing orders being reviewed. So I do have confidence, though, that those meetings will hopefully go ahead in the near future, and all the aspects that require to be discussed and, ironed out will be progressed. They won't all be in place from the 1st of September or for the October IJB. I will have to point that out. But I will certainly act in the best interest of the IJB as a service user representative. I've had a lot of support from the Healthcare Alliance, that's external support, and I'm really calling for the support from the IJB and whoever's relevant to get these local issues sorted out yet, because we don't have any dates that I'm aware for that. So I do have a little bit of concern, but I've also got confidence that they will be kind of sorted over time. And I know a lot of this is due to waiting the national guidance. Yeah, so that's quite frustrating, but perhaps not unexpected. I would just also like to note that I certainly, as somebody had mentioned about improving the culture, the inclusion of lived experience representatives, and I think I've said it at IJB meetings before that I certainly have found it's a very positive culture of inclusion of the lived experience reps here at Dundee IJB. So thank you for that.
And thank you for that too. And Dave, anyone else in the room?
Yes, Jim McFarlane.
Yeah, I mean, Sorry, thanks, Paul. Congrats to the individuals. Just kind of going forward around, you know, on the board itself, that, you know, on the current setup you have in the sense of, you know, staff side rep from the NHS, trade union side rep from Dundee City Council, is just looking, you know, trying to make sure that going forward, as a voice of the workforce, that will include obviously those employed in the third sector. So just kind of looking for, you know, some pointers around making sure that under the kind of fair work agenda and stuff that's in our Employment Rights Act and everything like that, you know, we can develop that culture, that we can be able to do that role as well within the workforce across the third sector as well, on access, you know, and negotiation and all the rest of it that should flow from that.
Thanks for that, Jim. One Martin, what's for that as well?
Thanks, Chair. In fact, Dave, I have to agree with some of the comments that being made by Nikki on respect to the report. There's some concerns still, I think, but that's something which I know this is just the first step in the process, and that we'll deal with in October and end of December, and any other future meetings that we need to deal with. So I'm not worried about that, but I have got some concerns. In terms of support delivered by officers, I have to state that Roger has answered every email or every question I've had without favour or without concern, and I must commend him on the work that he and his team do in that respect. And I know that if I need to ask a question, he's more than happy to answer. I'm just trying to decipher the legalese, you know, that's the heady part. But that in that respect, I'm happy with. In terms of the overall report, I am happy again with caveats and the concerns that Nikki and others have raised. And there's just a few things that need to be polished up. The national guidelines should have been out before now. They haven't been out, and there's been questions raised at national level with care groups. And I've got a meeting with them next week, in fact, to discuss the fact that this has not come out yet, because there's still concerns naturally about the issues that have been raised here and elsewhere. The standards in public life, the card that come out to say what we cannot do, again, has been wonderfully helpful in that respect. And again, we're meeting with them next week, so I'll be able to express that to them directly. In terms of concerns of being pressured by external groups, one of the things that I did a number of years ago was withdraw from being a member of any group that may be affected by this board operations, so that when I sit around this table and say what I say, it's an independent voice. It's not I'm being directed by Dundee Care Centre, or being directed by Pernimer, or being directed by whoever. I am sitting around this table as an independent voice without any sort of pressure being put on me. The only support I get from the Dundee Care Centre is travel and other elements, which is something that we've all agreed is perfectly acceptable. So there's that. On the actual report, I just want to make one question comment on 4.8.3 regarding the last sentence, primarily about implications for wider governance, structure including subcommittees, advisory group and other advisory groups. There's not clarity again nationally or from on papers about that, and I think that's something we need to probably have to deal with at another meeting. But again, that's not a major thing, it's something that we can deal with. But overall, I am happy with the setup. I'm happy with getting voting rights, have a proper say in the way of things are working. And thank you.
And thank you, Martin. And Dave, do you want to make any final comment before I move to recommendations?
Only in terms of obviously kind of helpful to have these comments today, and can listen to the concerns that have been raised around our kind of overall preparedness around this, and in particular having a specific meeting to discuss kind of those particular issues. So we'll commit to making sure that we have those arrangements in place for members to be assured that they're comfortable going into the future meetings with all information.
Okay, thank you, Dave. can we move to the recommendations under 2.1 to 2.4? Do we accept these recommendations?
Yeah.
Yes. I just want to say, I think these changes are, it's a great opportunity for the Integration Joint Board and the future governance of the organisation. But I think the key point, and without living this, is about the equal participation of the lived experience members, and I welcome that greatly. Thank you so much indeed. Can we now move on, please? Thank you so much.
That now takes us on to item 10, Dundee IJB Internal Audit Annual Report 25-26. You've got it for a decision.
Okay, I shall just briefly introduce this and then pass over to Barry. So members might recall that this report was actually presented previously in a June meeting, because of the late distribution of it. It's been deferred to today to allow members the time to actually really read and review the content of it. Jocelyn Lyle, our Chief Internal Auditor, previously actually talked through all the key points of the report. Unfortunately, Jocelyn can't be with us today. She's got another meeting that she's at. But I'm going to ask Barry Hudson, Regional Audit Manager, to pick up some of the key points from the report. It will probably be things that Jocelyn covered, but just under the actual governance process around this, there are certain things obviously that I think Barry has to actually specifically say. So again, we'll be covering that, and just sort of pass on my thanks again to Jocelyn, Barry, and their team for all their continued support.
Yep, thank you, Christine. Just on behalf of the Chief Internal Auditor, I just want to present this internal audit annual report for 25-26, which provides the Chief Internal Auditor's conclusions on the IJB's internal control framework for the financial year. This conclusion is based on the IJB's internal audits and prior year audits reported in year, relevant internal audit work carried out in the partner organisations, the 25-26 ICE, which is appended to this annual report, and progress with delivery of previous internal audit and other governance improvement action points. The IJB is asked to take reasonable assurance from this report in evaluating the internal control environment during 25-26. The draft ICE report was issued on 19th of May, and that highlighted a number of key developments in year. These include the IJB approval of the Strategic Risk Management Framework, the update of the Dundee DH&SCP Workforce Plan 2025 to 2028, robust financial reporting and updates and approval of financial regulations and scheme of delegation. And in addition, we commend the IJB development sessions on budgets, equalities, engagement and co-production, mental health and adult support and protection, statutory review of the Strategic Commissioning Framework. The ICE report highlighted potential year-end assurance issues, and there were 4 significant and 5 moderate findings. We also noted some items for consideration. The significant findings, the first one that focused on the need to report whole system transformation through governance structures. Secondly, we were looking at some robust action required to improve management of adverse events and the importance of effective oversight of this area. Third significant finding related to the importance of firmly agreed objectives and an appraisal process for key staff. And the final significant finding related to the potential impact of acting arrangements on finance team capacity. Robust management responses to all our findings has been provided, and all action is planned with reasonable timescales. Overall, the ICE reflected the clear trajectory of strengthening governance maturity, with some areas still to be embedded. Turning back to the annual report, we provide an update on governance developments since the draft ICE was issued, and that's included within your papers, and it includes reporting of the indicative year-end financial position at the point of time of doing the report, Internal audit work identified no further findings to include in the annual report. So there's a couple of bits that we have to say as part of this process. So based on the internal audit work undertaken during the year, my overall conclusion is that the IJB has adequate and effective governance, risk management and internal control arrangements in place. The Chief Officer has implemented a governance framework in line with required guidance sufficient to discharge the responsibilities of this role, and the 25-26 internal audit plan has been delivered in line with the global internal audit standards and the application note GIAS in the UK public sector. In addition, we've not advised management of any concerns around the following, which is the consistency of the governance statement with information we are aware of from our work, the description of the processes adopted in reviewing the effectiveness of the system of internal control and how these are reflected, the format and content of the governance statement in relation to relevant guidance and disclosure of all relevant issues. I'd just like to take the opportunity on behalf of Jocelyn to thank Dave, Christine and the wider team for their engagement and support throughout the year. And I also want to thank both the internal audit teams of the NHS and the Council for their work to delivering the IJB audit plan. I'm happy to take any questions, or any of the officers could answer any questions as well.
Thank you, Valerie. Appreciate that. Questions?
So we've got Colleen and Dorothy.
Yeah, thank you very much. Yeah, just a couple of my questions. So there's quite a number of ongoing actions that have been carried forward from previous years, and some of the current actions relate to our financial plan. I've got concerns about if we've got an inability to implement some of the transformation plans, we're quite relying on them to deliver some of our budget for this year, which we already know the situation with the gap there. So my question around that is, do we have the capacity to actually complete and close these actions within the agreed timeframe? And will we see progress of the action recorded against all of these recommendations in the October IJB, just so that we can up to date plan?
I think in relation to the first question, it'd probably better for Dave or Christine to answer. The second question around the actions, we acknowledge there are quite a lot of actions that are outstanding going back quite a few years, and we've got a meeting organised to try and rationalise some of these actions going forward. But all these actions are reported to the Performance and Audit Committee around sort of the follow-up of where they are. They don't formally get reported to the IJB meeting as it stands.
In terms of the other part of the question, things like the insurance, the transformation programme, which, as you say, is kind of critical in terms of our financial position overall. So we do have we do know what's happening in terms of the transformation programme, and what we've never done is actually put together a number of actually document that work is in progress now. And we've got our senior leaders working through some transformation programme support and to kind of taking that role and supporting. So go back to the previous reports on the different kind of savings items that were on there. That individuals kind of helping them kind of support to move those on. So we've not had that kind of focus on that resource in the past to do so. So from the start of this year, this financial year, we've now got that kind of resource dedicated to undertaking that. So now, in addition to that, we've set up an additional meeting that the management team will attend, or the leadership team attends, and that's a budget delivery group. And again, the transformation side of things is kind of picked up within that. So we have. So this is in addition to our kind of regular management team, it's a specific work focus on budget transformation.
My question was very similar and related specifically to the transformation programme and the significant detail finding in this report. So I'm not sure if I understand. The recommendation is consideration of formal and structured reporting process. Do I understand then this is going to be done and it'll come to the pack? Or is it going to be done at all? Formal, structured reporting on the transformation programme.
We'll be picking the internally, we'll be looking at actually what we're actually doing as part of our senior management team and additional resource Dave's mentioned in terms of project management and delivery of this. And my intention is part of that, and again, because it's a part of the governance action plan, it will be captured through that in terms of so the actions through our process. But I'm also looking at, as part of our sort of future annual financial reporting, of how we actually capture the key salient points around some of the delivery. And as Dave says, we know what's going on against different parts of this, but we've not actually put it into some kind of formalised structured report back to yourselves. And that's what we're kind of working on as to how. So it's part of the budget setting process and futures of budget and financial updates and pulling that part of the reporting to IJB.
Just to add that, so we will commit to kind of come back to IJB with future reports on that transformation.
The IJB on the pack.
I would put it. I would say it goes to the IJB because of the nature, because it's sort of tied in with the budget discussions within that. And again, it will go to decisions the IJB has made as well. Adding to that, because I just kind of looked at in terms of system transformation, so we don't work in a bubble. So there are particularly kind of large themes of work going on within NHS deciding of which we are part of. So there's work around our central care pathways, for instance, and that we can be part of that as part of the delivery of those services. So allied to that, what we are doing and we're kind of leading as an IJB, we've actually that wider work. We're involved with, and certainly we've done the same resource transformation. So how that kind of faces with the services that we deliver within the social care.
The timescale, as it's laid out here, is going to be tight then. It says September 2026. That is, you're not going to manage that.
That part is obviously is for us internally as a senior leadership team to be putting in the structures in terms of the reporting to IJB. That, yeah.
Right, okay.
Depending on, I can't remember if we've got anything.
Okay, that deals for internal discussions and planning.
Yeah.
Okay.
Okay.
Well, there's anybody else in the room? No.
Okay, thank you very much, India. Thank you so much, Larry. And we note the recommendations and the instruction within the recommendations. Do we approve? I take it that's a yes, Dave?
Yes.
Okay, thank you so much indeed. Thank you, Vari, and I'll see you at the next meeting. Okay, thank you. Thank you. That takes me to the next one, Arlene.
Item 11, financial monitoring position as at June 2026. It's for a decision.
Thank you. Okay, so this is our first report, financial monitoring report for 26-27 at the IJB, based on looking at projected financial positions on our delegated health and social care services and based on information as at 30th of June. Members will note that the format, layout and content are consistent with previous year's reports, and therefore hopefully it's relatively straightforward to follow. As mentioned, the position is based on information available at the end of June, and we're currently forecasting an operational overspend for this financial year of £2.1 million within the report. And this continues to reflect the significant challenge to deliver the planned savings and efficiencies of £11.8 million for this year, while also continuing to meet the increasing demand and maintain the required clinical care and performance standards. Section 4.3 and 4.4 provides narrative around the key aspects and drivers within the overall financial position. along with some of the underlying assumptions at this early stage of the financial year around anticipated trends and delivery during the remainder of the year. And a breakdown summary of the financial position is also noted in the appendices to the report. As the financial position continues to project an unplanned overspend for this new financial year, and is noted in section 4.6, the IJB remains in financial recovery from sort of previous years, and an updated financial recovery plan report will be presented to the next meeting in October for decision around that. However, in the meantime, it is actually recommended that the actions and controls that we'd actually previously put in for 25-26 remain in place at present. And certainly that's what we've been continuing to be working towards internally. But so looking for the IJB just to ratify that. In addition, as noted in section 4.8 and appendix 6, it was actually a recently produced National Health and Social Care Scotland report, identifying a number of similar financial challenges across integration joint boards across Scotland, including the rising demand, the inflationary pressures, and the difficulty maintaining investment in early. So of course, we're also responding to the pressures that we're all facing. And the report also recognises, which is useful to note and just to highlight as well, that interconnectedness of how decisions on delegated services and delegated funding often have consequences across the wider system. And that's something obviously that we continue to try to manage and balance with our partner bodies and also with our external commission services as well as our internal service. Dundee's position, as would be no surprise to hear, is consistent with those wider national trends that are being faced across Scotland. Members are asked to note the current position, approve the continuation of the existing financial recovery actions from 25-26 year, and instruct an updated financial recovery plan to be submitted in October 26. But happy to pick up any questions or key points from the report if anyone's got any comments.
Okay,
thank you.
Dorothy's got that up.
Thank you, Christine. It's not easy, is it? It's not good news ever, is it? Talking about funding. 4.3.14 talks about supplementary spend during the first 3 months of 26-27 of 2 million. This apparently relates to part-time, additional part-time hours for time agency staff. My question is this an outlier? I'm hoping you're going to say yes, or is it a trend? Hoping you're going to say no. Maybe you're not able to answer that, but give me a best guess.
Yes, so as it's pointed out there, so the first 3 months of supplementary staffing spend was just over £2 million, and the comparable period for the previous year was 1.2. So it does look considerably higher. However, I would say that there were a number of unusual or individual sort of circumstances through that first quarter, where different things have been implemented, and there's perhaps been a short-term additional reliance on supplementary staffing. So I'm hoping that this is not a trend that will be continuing through the rest of the year. There has been one of the aspects was that the national implementation of reduced working week within health boards for agenda for change staff, and that also coupled at the same time with the pause on recruitment and some of the controls around recruitment in both council and NHS, but particularly within NHS. So additional funding has been provided to support some of the reduced working week. But we weren't able to actually recruit additional staffing at that particular time. So there is an element that I think is impacted in terms of additional supplementary staffing in the short term, to manage that change. But obviously, there will be an element of very close monitoring around that. And I think from the national NHS Tayside position, all areas were a bit higher in terms of supplementary staffing spend for that first quarter as well, which we believe is probably linked directly to reduced working week and the recruitment clause at the same time.
Okay, thanks, Christine.
David,
yeah, just on the back of that, because I mean, there are ups and downs through the underspends, overspends throughout the paper, we can see that and we expect that. But the supplementary spend, because it does feature all the time, and highlighted in the summary, the bulk of it, as I understand, is really in mental health.
Supplementary staffing is probably right across all our areas. Don't know the detail here.
I'm just picking up because, you know, at our forecast, we've got, well, between mental health and learning disability, we've got £3 million, potentially overspending 100%, for saying that there's £2 million of supplementary spend. That's got to be a major feature, I thought.
I think possibly a lot of supplementary staffing spend will have come through in our patient facing and inpatient or residential services as well. So some of that will actually be older people and other services as well.
My one other question other than that was just for clarity, shall we say, just when, because we do give a good detailed breakdown here, the summary table, and then I'm looking here at page 247, 248. It's for clarity, on the lead partner services, we're showing an £822,000 underspend on centrally managed. And then under other Dundee services and support services, we're showing £1.8 million overspend when the budget today is only 3.2 million. So it's a huge overspending on the budget. So I'm saying, are they self?
There probably will be aspects of that I share. I maybe need to look at the categories and tell you some of the reporting that's up. So I suspect there will be an aspect of reporting oversight and reporting crossover between the two lines there. So I'll have a look at that just for.
And I think the final wee comment and wee question here is Chair, is that on the significant, there's a lot of number of factors here, but on the significant ones, so I'm kind of highlighting on supplementary spend and you can see is the extra spend in mental health and disabilities, etc. And the support services, how confident are we that at this stage that our overspend because of these can remain circa 2.1, bearing in mind that effectively we're talking here about the first quarter. I mean, how well forecast is that, if you know what I mean? Because I mean, that's 2.1, we don't expect that to increase proportionately as the year goes on.
So the 2.1 is based on a number of assumptions for the full year around that, based on the trends that we saw through the first quarter. And as I've said, some of the underlying reasons that we think some of those trends are anomalies in terms of an ongoing trend. We do have a very challenging financial position for this year. We probably don't have an awful lot of scope for any new or unanticipated or unplanned aspects of service that might be coming through. So again, that part of the senior management budget delivery group and the wider operational management teams, and that link between our financial team and budget holders, we continue to have these kind of conversations on a regular basis around looking at what's coming through, what's the impact, the risk, and where and how we're all delivering around the plan savings for this year. And as if things change, then obviously that will be reported through into future financial reporting and pull that through around where things that may have either slipped or improved as well, potentially as well, in terms of some of that trajectory that we need. But it's been closely looked at and closely supported and monitored.
We don't expect that figure to go down, do we?
I would like to think it might, but I'm realistically, given the additional accompanying report that came for the rest of the IJBs, and the financial challenges are really significant, and the demand pressure that's coming through, and how we actually utilise those resources that we have available to us are very critical in terms of that prioritisation.
Good, Raymond's.
Yeah, I want to go back to the reduced working week. So my understanding is that the allocation from Scottish Government was specifically for reduced working week. And the IJB was allocated that portion of that. Can we get some assurances that, because that money is specifically for to offset the impact of the reduced working week, so therefore will that be used to support the additional resources required for staffing in relation to the reduced working week?
So the money that came through from Scottish Government actually covered the three aspects of the Agenda for Change reform. And some of those costs are still emerging, obviously. So that we have a totality of a pot within Tayside, and part of it for reduced working week, and to manage that, part of it for the review of the band 5 to 6, and also part of it for protected learning time. We have a distribution of funding out to the partnership. I'm still working with the finance team and senior and the senior management around how that's actually distributed to individual services. So rather than necessarily replicating and backfilling every single half hour that was 1 hour, should say, that was changed, there may well be different opportunities that different services might look at in terms of pulling that together and recruiting to one larger post. So that will be distributed. However, the funding that's being distributed at the moment has that totality of funding has been calculated that it doesn't actually cover every single part of every hour that has been changed, and there has been a formula to distribute that. But it continues to be monitored across Tayside around what's the impact. There are some services that they've actually reconfigured their workforce and their delivery of service, and therefore are managing their demand in a different way, having absorbed the reduced working week, but not actually impacting directly onto their patient facing or clinical time. So there's aspects there that there's actually opportunities for efficiencies.
Can I come back and think what you said as far as that? So the money will be used to support the elements of the reduced working week. I get that. We're not near any end point for the protected learning time, which I'm concerned about. You know, we're behind, but I think everybody is not just. I'm sorry. The band 5-6 changes will gradually get progress as they do. I think we're concerned is that I think you said that I get the point that we might not be able to just allocate a half hour here and there, and there's services for some services. But I think what you are saying was the money will go to delivering the reduced working week as it was laid out by Scottish Government. I'm just concerned with issues elsewhere.
No, I said we know we will distribute it to the services into it's almost like pots to allow them to determine how what's the best use of that and what's the fairest use of that. But there are aspects where some services do not require the total backfill in the same way that others might. So there's different ways that individual services have looked at how they manage the change in the reduced working week forward.
Okay, are there any, Dave, are there any further questions in the room?
No, I think that's us clear in the room.
Okay, thank you. Can we now move to the recommendations set out in 2.1 to 2.4? Do we accept these recommendations?
Yes.
I take it that yes. Thank you. Arlene?
Okay, so item 12 we've already dealt with. Item 13 is the meetings of information during board attendances, which is submitted for information. Item 14 is just to note the IJB development sessions that have been arranged. And item 15 is the date of the next meeting, which is 21st of October.
Thank you very much indeed. And I think, as I've indicated before, this is my last meeting of the IJV, and I just want to thank all the members and the officers, and also particularly thank Ken and Dave and Roger and Arlene for their support throughout this time as well. So I just want to thank everyone for that, and thank you.
Thanks, Bob, and I'll take the opportunity to thank you as well for time well served on the IJB. You've been with us for a number of years now, and we've valued your leadership and your knowledge and your insight and what you brought to the IJB. So that kind of experience that you've had from a long career and kind of been able to bring that into our discussions here and help set the direction of the IJB. I think you chose the most challenging IJB meeting project as your last one. So thanks again for stepping into the chair today. And obviously we're still having it for the next performance and audit committee. So we'll get through this all again. But I'm sure our IJB members would join me in thanking you for your amazing service to the IJB and the citizens of the IJB.
Thank you. Meeting's ended, I think.